As per the Pioneer HF study, hospitalized patients with acute decompensated heart failure, ejection fraction less than 40% were looked at, and around 900 patients were there in the study. They were stabilized while still hospitalized. Like if SBP was more than 100 in prior 6 hours, there were no symptoms and BP was not dropping. There was no increase in inotropes over a period of 24 hours, no increase in IV diuretics or vasodilators in the last 6 hours. Such patients were taken in the study and were compared enalapril 10 milligram BD versus ARNI 200 milligram BD was the dose. And they were studied. This study was followed up for around 8 weeks. And what they found was there was a significant decrease in NT-proBNP levels and improved clinical outcomes like even cardiovascular death and hospitalization. As you can look at these Kaplan-Meier survival curves, and there's a significant difference between enalapril and ARNI vis-a-vis change in NT-proBNP levels or cardiovascular death or hospitalization. Now, there were pre-specified subgroup analysis also done in de novo heart failure patients, and in all cases, whether de novo, whether worsening chronic heart failure, whether patient were on ACE inhibitors or ARB or not on ACE inhibitors, in all kind of patients, there was significant improvement in NT-proBNP levels at 8 weeks once the patient was switched, or rather compared with an ARNI as compared to an ACE inhibitor. Such improvement in early clinical outcomes would be lost in a scenario of ACE inhibitor or ARB pretreatment. Pioneer HF, if you look again, the change in NT-proBNP levels was very significant, and cardiovascular death and heart failure hospitalization also was very significant. And you could see early clinical benefits as early as 14 to 15 days. So I think you have to start ARNI very, very early in the, as per the Pioneer HF trial, ideally before discharge.